for this interesting concept on the biomarkers that you asked me to talk about in AMD. And as we all know that in healthy macula, there's a lot of nutritional transfer which happens across the RP Brooks barriers. And as aging takes place, wear and tear takes place, you have deposits of the drusense, which leads to the dry AMD, and then the soft drusense, and then at times you have the leakage and the vessels growing in, and which causes the neovascular membranes, and which is what causes a lot of visual disability for the patients which we treat. So there is an apparent lack of sensitive and robust biomarkers for the management of this AMD, and we probably need to have more customized guidelines rather than have too many general guidelines that we work on, because every patient, every eye behaves a little differently. So there are a lot of tools that we use. There are certain general ones which we have been using for many years, and there are some which are constantly advancing and giving us new information. The color pictures, of course, we've learned from a long time of how to interpret a drusen and the possibility of drusen going into an wet AMD or a soft drusen, having a more preponderance to go into wet AMD or a severe visual loss. And then there's autofluorescence, which gives you images and how when you interpret them, looking at the hyperfluorescent areas, you look at those spots which tell you that in the future the same areas will go on to increase in atrophy, and it is quite proven by a lot of work done by the imaging people in this field. And then there's fluorescein and ICG angiography, which have their specific interpretation, which one can look at where is the active leak, where is the recurrence, and then look at a predictive outcome of where that lesion is going to head to. So there is fluorescein, this is ICG. There's also a combination of fluorescein and ICG we use in certain cases where there is blood masking the central area, and you look at a hot spot or a feeder vessel channel which opens up on an ICG. So we've learned over a period of time that in what conditions what we use to initially establish a diagnosis and then see what is the predictive value of that diagnosis in terms of how it leads up. And then there's OCT, which has got a lot of biomarkers which have been studied over all these years. I won't go into the details of all of them, but things like central retinal thickness, a PED, or a pigmentary epithelial change, shifts, all those, lot of things, atrophic changes, how the layers behave, have been used for predictive outcomes or recurrences in these cases. So that have been there. And here again you'll see a lot of changes which have been published related to how the pigment epithelium layer atrophy at certain places and how it leads up to progression at times. And then of course there is choroidal thickness, which is very important. Now OCT allows you to do a deep evaluation where the choroidal thickness is now noted well, and it's well known that the healthy eyes have a thicker choroid compared to as you go on towards a pathologic AMD eye. So now we come to the new OCT angiography based one, because this is something which has come up in the last few years. So till now we were working more on the OCT, and then the OCT angiography is now showing you different dimensions where you can see vasculature at different planes from a superficial to deep level, and which is giving us a new understanding. And of course it's a new understanding, we still don't know how to totally interpret it, but a lot of learning is happening. So this is an active vasculature which is treated and it disappears with an anti-VEGF molecule, and that's how the vasculature is apparent with OCTA. So when we say OCTA based imaging biomarkers for activity which show activity are the CFAN morphology, secondary branching, peripheral arcades, perilesional loops. So all these have been mentioned by a lot of investigators, especially a lot of work with Sada and Saraf. They've been bringing up a lot of data on these things. And if you look at inactivity, there's large dilated straight vessels, absent secondary branching, lower peripheral arcades, and so on and so forth. So does the lack of fluid mean on the OCT means absence of CNV, or does activity persist despite lack of fluid? So when you look at OCT and you are retreating, these are the questions which come to your mind when a patient keeps coming back to you with visual complaints. So OCTA is further defining, helping us look at aspects beyond just the OCT itself. So there are long-term evaluations of the type 1 CNVM, which could be growth rates, growth patterns, growth forms. when you look at the growth rates, the doubling is seen even as you treat these patients. There's a doubling of the actual vasculature that you see, or there is a modest growth that you see instead of the one you saw before, or there could be a frank reduction of the CNV. So we see all these formats which are happening, and we are still understanding what the predictive value of seeing any one frame at a given point in a patient means in the long run. Then there's 3 growth patterns which could be symmetric, something like this where there's a symmetric increase, or there could be an asymmetric increase where it's not growing in all directions in the same symmetric fashion. And then there are finger-like projections, which are podia-like the projections which come up in these patients. So all these are differently presenting features. Or the growth forms, which could be immature, mature, and hypermature. Something like this, you have various divisions of these immature forms, or there could be maturity, which has a modest stable growth and is supposed to be more resistant to the anti-VEGF therapy in these, or hypermature, where there is large straight vessels, dead tree appearance, and inactive growth. So these are the further biomarkers. Just to explain, one of our patients who we were treating for the other eye had these sort of changes on the OCT. You see these bumpy excrescences near the pigment epithelium. OCTA showed these darkish spots, and then over the next few months, even though we were not treating this eye, it went on to develop a PD with fluid around, and some changes of vasculature that we started seeing on the OCTA. And then we gave anti-VEGF, and there was a bit of a regression which we could see. But again, there was a recurrence, and you can see that it kind of regressed, and then again, as we were treating, at some point the recurrence started, and there was another front which came up. So what I mean to say is that we still don't know. It's not as straightforward that you give injections and it's, of course the patient responds, but we don't know that is this the end point, or is this a new vasculature sometimes comes as a part of recurrence, or is the same one which is opening up. So short-term biomarkers may show correlation with disease activity with poor predictive value, while long-term biomarkers may provide more reliable biomarkers of neovascularization activity. We put some of our work in Retina Today some time back. I don't have much experience with this. I think the Narayanitra people have adaptive optics, and there is a lot of mention of this work where the photoreceptors are looked at with in a lot of these conditions, especially AMD, and looking at the health of the photoreceptors and predicting the functional part of it, how they respond to a stimuli during the test, and would predict what it leads up to in the long run. To conclude, there is a distinct need to identify sensitive and robust imaging biomarkers for individualized prognosis of AMD, which would help clearly define endpoints of treatments and retreatments. And to end with, I just want to show you a small clip of this friend of mine from Vienna who does a lot of work on software imaging of all these OCTs and 3-dimensional ones. And he was showing a few years back a choriocapillary which was rendered in 3D from the data captured on OCT. And he could go and from that data create this whole network where you are actually going inside and looking at the health of the choriocapillaries and looking at how thick or thin they are, what is the passage like, what is the lumen like. So there's a lot of stuff which is in the offing where imaging is concerned. What we know is just the tip of the iceberg, even though there's a lot of stuff which is around. But the more we know, I think it's going to help us in the future with trying to do these treatments to a more customized manner, as well as when to consider retreatments in times of dilemma when a patient has a fluid or not, which is there or not there based on the visual acuity and symptoms. Thank you very much.
Yes. Yeah.
You showed a patient, other eye, who had a Duchenne, soft Duchenne, and in follow-up he developed a neovascularization. So as we had been following the patient for last many years for that other eye which was not having good vision, imaging does not only help to get the exact diagnosis, but I feel learning from the other eye, we could set a pattern of treatment also, so that we could save that same problem in the other eye. Because to tell the patient that the same problem has occurred in spite of your frequent watching is very embarrassing to us as a retinal specialist.
Yes, no, I agree. But But our understanding so far doesn't allow us to treat that eye because we don't see an active
Do
membrane,
you
active
feel
fluid.
there's any genetic
Yeah.
biomarkers
Yes.
for these patients
Yes.
who already have a disease in one eye?
Absolutely. So we need to find out what is that marker in that patient which brought on the activity in the few months that you were treating the other eye, is where the question mark is.
Yes.
If you have a perfect imaging tool, like I'm asking a hypothetical question, what would be your biomarker? You showed that capillary thing, but those are just a great image. But
Yeah.
but in your present scenario, what would be your biomarker?
The present scenario would be, I think, it would be asking too much if we have a predictive value for both eyes to go on to develop something. But I think if one eye has a pathology which we know is bilaterally possible, so we need to define a biomarker through the active eye to determine the minor changes which happen in the other eye, that whether they will definitively or almost definitely go in for something. So there should be something on that image based on that so-called perfect tool which tells us that info. But I'm not sure that I could expect something that in a totally normal eye, it's too far. I mean, that would be great to know that this healthy eye is going to go into an AMD or IPCV or something. I don't know if that is possible. Maybe in the future, yeah. But today, given the whole scenario, the information, I think we should be able to get on to some sort of an imaging where the other eye prediction could be done.
Manish, I have a suggestion. If we look into the epithelial or the rod and cone function at watching a ERG, because we have a new machine which can predict the ERG function of a normal retina. So these predictive values of ERG can also help, I think, for the future progression of the disease in the other eye.
Right.
See, one of the things for any prediction, the best example is what was published few days back. They've been able to look at the vasculature of the eye and predict the heart attack. To get that prediction, they have done 238,000 eyes of patients having heart attacks and vascular
Yeah.
change.
Yeah.
So they built this into a big data system, and then it went into an algorithm, and then it can start predicting.
Like we do know that ischemia is one of the triggering points for the VEGF activity, which leads to the neovascular component. So if we have a biomarker which tells us that there is an onset of ischemia there, which is what in the future is going to lead up to a membrane, I think that would tell us a lot more rather than just looking at RP or like just the layers, which of course happen at a secondary stage.
Yeah.
What we are looking is already the damage is already in progress, but the initial stimulus is based on ischemia
Changes.
somewhere. Yeah.
Finally, it boils down to genetics. Like if you may have all kinds of markers, but you may never develop an ARMD because your genes are protecting you, and you may have a very small marker. So the holistic approach of connecting all would be like what you're doing now, would be the way to move forward in the next decade.
Sure.
Thank you, Manish.
Thank you.
Yes, sir. Be ready.
Rohit is the guy. He's already
No, the
suggesting
only
you
thing
that,
is, see, the question is behavior changes would be, smoking is linked to your ARMD directly, the nicotine. So I'm not really sure whether alcohol of any sort is linked, because I know wine, the component in wine actually promotes healing better. This is what we published. I don't remember the name. It starts with R. I don't know if somebody can remember that name. So wine is actually a protector, but you need gallons of wine to protect you against the not.
But when you have gallons of wine, you'll anyway see fuzzy for that time.
So that is one thing about it. But smoking, yes. And if you stop some, and the new components of ARDS, I don't know how much you believe in that. The oral supplements, do you give them?
Well, but it's more of a placebo. See, all the guidelines, what they suggest, the amount of antioxidants that they actually need is practically impossible for the patient to take. Is what is the problem? Because what we give is actually a very small amount of the dosage which is suggested, even though the composition matches
RH1,
RH1. But then you're supposed to give a lot more of that, and I'm not too sure if that works very well with them. They all have a lot of symptomatic issues with taking them. So I do give them, when there's an active AMD in a patient, we do give them but I personally feel it's more of a placebo or it's more of, I'm not sure if it makes a difference.
I think these patients who are going to develop blindness in other eye, so trying pranayama and deep breathing exercises, because it is basically related to the anoxia.
Like he said, anything which can give him hope.
More oxygen, yes.
And then how much it works.
Not wine, not wine.
Thank you, Manish.
Thank you.